Welcome to Texas Heart Institute Living Legends and Luminaries podcast series. I'm Zvonimir Krejzer. I'm an interventional cardiologist at Texas Heart Institute and Baylor St. Luke's Medical Center. Our guest today is Dr. Martin Leon. Martin Leon received his medical degree from Yale School of Medicine and completed his internal medicine internship, residency, and cardiology fellowship at Yale New Haven Hospital. Dr. Leon's illustrious professional career in cardiology continued as a director of cardiac catheterization laboratories at NIH in Bethesda, Maryland. Later, he became a founder and director of clinical research at Washington Hospital Cardiology Center and clinical professor of medicine at Georgetown University Medical Center in Washington, D.C. From there, his career continued as a faculty member for the past 22 years at Columbia University Irving Medical Center in New York, where he is currently the Mallah Family Professor of Cardiology. Previously, he was the director of Columbia Center for Interventional Care and director of the Cardiac Catheterization Laboratories at New York Presbyterian Hospital, Columbia University Irving Medical Center. Recently, he was appointed as the Chief of Innovation Officer and Director of Data Science for the Cardiology Division at Columbia University Irving Medical Center. Dr. Leon founded and has been the Director of Transcatheter Cardiovascular Therapeutics, TCT, and CRF since 1990 in New York City. TCT is a world premier scientific symposium dedicated to interventional cardiovascular medicine, which celebrated its 37th anniversary this year. This international CV meeting attracts over 12,000 attendees from over 100 countries. Presently, CRF is the largest independent cardiovascular research and education foundation in the world, focusing on innovation, preclinical science, clinical trial development and management, and educational activities. Dr. Leon has been the national principal investigator or study chairman for over 75 clinical trials that have helped to shape the interventional field. The list of Dr. Leon's contribution to clinical trials are STRESS, STARS, Gamma-1, Sirius, Endeavor, Resolute, and more recently in TAVR trials such as PARTNER trials, Early TAVR, and more recently for tricuspid, Transcend trial, and Champion AF. He has authored or co-authored more than 2,500 peer-reviewed scientific publications and abstracts. Dr. Leon has been a clinical practitioner and procedural operator during his entire career and has performed more than 10,000 procedures as an interventional cardiologist. He has also been the director of or co-director of more than 100 international educational programs in interventional cardiology. During his career, Dr. Leon has received more than 30 International Career Achievement Awards, including the prestigious ACC Lifetime Achievement Award in 2019. Thank you, Dr. Leon, for joining us for the podcast series, THI, Luminaries and Legends in Cardiovascular Medicine. You're certainly one of the leaders in the field, and it's a special pleasure to have you in this program. As you know, we are working in a similar field. I'm an interventional cardiologist, and I started very early in 1980, and I'm sure you started close to the same time. And I remember meeting you for the first time somewhere in the mid-'80s when you joined one of our symposium that Dr. Cooley and Dr. Robert Hall organized in Houston, Texas. And I believe at that time you were still at NIH. Let's start from the very early beginning. What really made you decide to become a physician?
That's an interesting question. As with many things, you make important life decisions based upon personal experiences. I come from a family that had no physicians, but experienced some serious medical problems. My older brother died when he was a youngster, And that event really had a direct impact on me. And I became aware as to how traumatic it was to lose a close family member, particularly a child. And I made a decision at the tender age of 6 that there could be nothing more important than me becoming a physician. And I never wavered from that decision. And at every point in my life, there certainly were different pathways that I took, but I was really impacted by the personal tragedy of loss and the ability to be able to, as a physician, provide both comfort and also the expertise to avoid those things. So that life-changing event really set me in a trajectory that I haven't wavered from, and I've been a physician now for 50 years.
Thank you very much for providing this information. Now, you had your initial training in medicine, medical school, and later in internship and residency, and also in cardiology at Yale University. So what was the reason and who influenced you to go into cardiology?
Well, as with most of us, you have mentors and people that really help to direct your course. And the chief of cardiology at Yale at that time was a wonderful clinical cardiologist by the name of Lawrence Cohen. And he had done some of his clinical training at the NIH. And I was really impressed that he was both a great clinician, but he, for me, introduced the idea that doing research is extremely important, and it really sharpens your thinking as a clinician, and the two really feed on each other. So through him, I directed a lot of my thoughts towards cardiology, and also beyond Yale to spend time at the NIH to be able to gain some of the skills that I would need to become a more effective academic cardiologist. And in other ways, I have to say again, personal experiences shape your thinking. And early in my career, I also had personal issues with family health that directed me to cardiology. I, from the very beginning, felt that cardiology was where I wanted to be. And even as a medical student at Yale, Yale was interesting because they had a thesis program that was a very unique environment. And I did my thesis with Larry Cohen in cardiology, looking at ways to be able to diagnose heart disease with non-invasive methodologies. But it's all a matter of mentorship, Svanko, as you know. And I was fortunate to have wonderful people around me.
Interesting. So I guess from Yale in New Haven, you went to NIH, correct?
Yeah, I spent 9 years at the NIH.
So, and you were in charge of the cath lab and education program and so on. So what were those years like, and how did they really form your career as an interventionalist?
Well, the NIH was really a playground for me because I really had the opportunity to first meet some extraordinary people. It was at a time just after Brownwald had left, but Steve Epstein was the chief of the cardiology division, but I became close to people like Bob Bono and Pat O'Gara and Barry Marin and people who were really outstanding human beings, role models, and academic cardiologists. Sharpened my clinical skills. I had an opportunity to direct a cath lab, and I had access to all the NIH has to offer. So I became interested in experimental medicine and did a lot of work in the animal laboratories, learned about animal physiology. I worked with biomedical engineers and learned about device development from people who were really very excellent in early phases of med tech and device development. Those were the early days. I did some of the early work with Julio Palmaz, with some of the bare metal stent work that he was doing at the time, and Richard Schatz. And then I became interested in clinical research. So I learned evidence-based medicine. And so those areas really helped me to be able to gain some of the skills that allowed me to mature as an investigator and as a clinician. So the NIH was a terrific environment for me.
So after that, I guess you moved to Washington Hospital. What was the reason to change the institutions, and how did this influence your future career?
Well, the NIH was a great place, but the NIH is not a place where you stay your entire career. At the age of 39, with a wife and two children, living in Washington and being director of the cath lab, I had an exit salary of $52,000. So it was clear that I had to grow up and take care of my family, but at the same time, to be able to get into an environment that could take a lot of the skills and experiences that I had at the NIH and translate them into a different environment. So the Washington Hospital Center was a fascinating place. It was an extraordinary clinical environment, but hadn't done very much in the way of research. And they gave me the opportunity to build a clinical research program within a clinical practice environment that was doing 5,000 PCI. And I joined a group where 4 cath lab directors from hospitals in Washington all coalesced in one group. And that's when we formed a cardiology practice. That's when we built the Cardiovascular Research Foundation, and that's when we founded TCT, all in that environment. So it was the admixture of a academic and private practice environment that gave me the ability and allowed me to be creative in building models that ultimately became very successful.
You might want to mention the key individuals that help you in the programs while you were at Washington Hospital. Some of them are truly luminaries as well in their own right.
Well, Kenneth Kent was with me also at the NIH. I worked with him. I did my first angioplasties with Kenny Kent in 1979. So Kenny Kent was one. The other was Gus Pichard, who was one of the cath lab directors who formed the Washington Hospital Center, Lowell Sattler. So many great people. I was very, very fortunate, again, to have partners that really respected the idea of trying to build a clinical research department within a clinical enterprise. And then we quickly brought some very key individuals. Jeff Popma joined me out of fellowship, and we formed the first angio core lab. Roxana Moran joined me after her fellowship, and she's now the newly inducted president of the American College of Cardiology. So many people that we really developed in Washington have in their own right become very successful.
And I guess we should also mention a few other ones that were also very influential and have achieved quite a bit, like more later on, like Ron Waxman as well, correct?
I hired one. I brought Ron Waxman to the Washington Hospital Center in the late 1990s. Yes, he was certainly among those people. Yes.
And John Laird and so on.
John Laird was the first person we brought to develop an endovascular program, and he became absolute treasured colleague and friend. So, yeah, we were very fortunate to have some good people around us and to attract some great talent.
So this was the time when your great ideas evolved, which really kind of shaped the whole format of education and research in United States, I would say, with establishing TCT, establishing CRF, TCT-MD, and many other entities that are very popular in education and research at the present time. How did this come about at that point of time? What was the unmet need that stimulated you to move in that direction?
Well, it's very interesting because, first, TCT happened. The impetus for TCT was a series of circumstances. I was doing very early stage device development at the NIH, working with stents, working with atherectomy devices, doing work with intravascular imaging and laser angioplasty. And that was at a time when several really pioneers in the field, Andreas Grunzig, several others had passed, and Jeff Hartzler became a friend, and he really stimulated me to do something because at that time, really, angioplasty was largely related to balloon angioplasty, which I felt was an interesting technique, but really could not sustain to really shape a transcatheter therapy field. So we set up what we thought would be a boutique course with about 200 people and some live cases in 1988 at the basement of the Omni Shoreham Hotel, and that was the first TCT. And we really wanted to explore the idea of what device development would be in angioplasty beyond the era of the balloon. And that was the beginning of TCT, and it evolved from really a boutique course in a very early stage device development into what became a curriculum that helps to define the field. So that was the beginning. And then when TCT matured, soon after that, we realized that it was important to create an environment, an ecosystem, beyond just an educational event. And that was the genesis of the Cardiovascular Research Foundation, where we thought that we would really try to germinate ideas for therapy development and create an environment that would allow us to be able to study them in a preclinical environment with great animal labs, in a clinical trials center that would help us to be able to explore first early human investigations and then pivotal clinical trials that would be embraced by the FDA and allow us to be able to get new therapies approved, and then to have an educational activity that would allow us to be able to teach our peers, mainly peer-to-peer teaching, to be able to express what training and education would look like in this early field. So we wanted to have all aspects of that device development cycle and to develop programs and expertise that would allow us to be able to help to mature new ideas and therapies. And that was the genesis of CRF. So it was born out of need. Part of it was attached to the early days of TCT, but it built on many of my early experiences at the NIH and in clinical medicine to try to see how we could do this. And remember, we did this not in a pure academic environment, a university, but we did it really within a private practice structure and created a highly academic series of programs. We built the first angioplasty database, and during the decade of the 90s, from that database, we published over 1,000 manuscripts, and that became the evidence base to be able to help grow interventional cardiology.
Yeah, this is absolutely amazing, Marty, that it doesn't exist anywhere in the United States or abroad, because there are many meetings, or I would call copycat meetings, that exist worldwide, but none of those programs incorporate all the components that you have established within CRF, TCT, TCTMD, and many other entities that you have really started, which is truly unique in a way, that obviously required a lot of thinking, a lot of expertise, a lot of dedication and hard work, and help from others.
Yeah, I have to say that I was very fortunate. I've always embraced the idea that you have to surround yourself with the smartest people. And collaboration for me is very, very natural. So I feel challenged to have really good people around me in positive ways. And I love the idea of team building. So I've been fortunate, and I've had fellows from all over the world, they've become very, very successful over the years. So I think it's this spirit of collaboration, the thirst for continuing to try to not just operate in your sweet spot. You have to challenge yourself frequently to be able to continue to evolve. I think those character traits have helped me to become successful. But I am truly humbled by the people around me and the people that I've helped to train and that I continue to work with. So I haven't changed very much, to be honest. I'm still always looking over my shoulder and trying to see how I can continue to improve. I feel very, very fortunate to have been surrounded by so many excellent people. And right now, probably among the most important things in my life is to be able to mentor young people. And I'm really blessed. Around me, I have so many people at Columbia and at CRF that I work with on a daily basis, and they continue to be challenging. They're going to be superstars in the future, and to be part of their careers for me is very rewarding.
One of them is Juan Granada, who has done a tremendous job for the last, 4 or 5 years since he took the position of the president. He's truly doing a tremendous job. He trained here in Houston as well. So we're very proud of him to be able to achieve all the goals that you probably gave him as a task to do it in a year or two.
Well, I have to tell you, he's one of my closest friends. I am so thrilled with his progress and what he's accomplished. And he's becoming a world recognized figure for the work he's doing in innovation and the work that he certainly did with us in our preclinical laboratories. He's a superb talent in so many areas. So you're right, Juan Granada is one of the special people that really has emerged in our group. And that helps to sustain the environment. You develop people like that and they become the leaders, and you give them what I call headroom, opportunity to grow. And you see that over time, how they can develop in exciting ways. So Juan is a perfect example.
So if I remember correctly, the first CRF president was a non-physician, Marv Woodall. Is that correct?
That's true. I worked with Marv in the early days of bare metal stents. When I was at the NIH, I became the first consulting medical director of a company called Johnson & Johnson Interventional Systems that he was the president of. And that was the first Palmar-Schatz stent. So I got to know Marv, and Marv is still on the board of directors of CRF.
Marv is a dear friend of mine, and we work together on multiple ISCVS programs that Ted Dietrich established, and we work together on different educational programs worldwide. So I think that was definitely a good choice. But then you transitioned to physicians, basically cardiologists, to run the CRF. And so what was the reason to do that?
CRF went through several transitions. We moved from Washington to New York. The needs changed. We needed people with different skills. And we learned what it was. We didn't realize that the operation would grow to the extent that it has. Right now, CRF has over 250 people that are dedicated to research and education in New York. We have preclinical labs. We have a large clinical trial center. And we recently have joined with the Fogarty Innovation Center to be able to really continue to develop our ability to innovate, to teach, and to mentor people in new models of innovation. So we needed different skill sets, and felt at various times that having physician leadership was going to be very important, because everything we do is still centered around the patient. And unless we don't place the patient imperatives at a very high level, that sometimes we lose our center, our core. So having very good physician leadership, and we do have very good physician leadership, has helped us administratively to be able to grow CRF.
Very interesting. Now, let's go a little bit more into future. What does the future hold for CRF and TCT? As you know, we are approaching exponential growth of AI, and the meetings are changing in structure very rapidly. So what does TCT look like in 5 years from now? Is it going to be still in person, or is it going to be virtual, or a combination of both? How is this going to evolve with AI rapidly progressing into the field of cardiovascular medicine?
That's a great question. And we've thought long and hard about whether or not in-person meetings would not survive the digital age and now the AI experience. And of course, we lived through a pandemic where we didn't have an opportunity to be able to be together in person for a few years. And I must say that a meeting like TCT was founded on some very specific principles. And the principles had to do with being able to embrace evidence-based medicine, being able to use the live case format as an effective teaching tool in the field of transcatheter cardiovascular medicine, being able to have global collaborations, which we felt were very, very important, and to stress innovation. And those four pieces have remained the four cornerstones of CRF and TCT. We learned, being separated from our colleagues, that the experience of connecting in person, networking in person, sharing things with people that you've known for decades was still a very important component. So I don't think that TCT will ever be replaced by a fully digital, non-in-person format. We'll continue to evolve the format in as many ways as we can. Now we're less encyclopedic, less comprehensive by intent. The lectures are shorter, the discussions are longer. The format that we use is different. We still do many live cases, but they're performed differently because they're extraordinary lessons for us. Many are pre-recorded and edited in special ways to be able to accentuate the experience. AI has become a fundamental component. In fact, we plan the program using AI processes now. And we plan the faculty and we integrate the faculty using AI. Soon we'll have avatars that'll be part of the teaching experience very quickly. We'll do our best to embrace and continue to take leadership roles in how we format educational events, how we train physicians. But I don't think we'll get too far from our core, at least for the foreseeable future. We hope that we still will be able to be meeting people in person, to be able to engage early career faculty and try to inspire them to greatness. And much of that goes beyond the podcast or a digital video format. So I'm hoping that TCT will evolve, but not get too far from its roots, at least in the foreseeable future.
So let's talk a little bit about structural heart disease and in particular about TAVR and early beginnings. And you were involved from a very early beginning in TAVR field. And I wanted to ask you, what were the beginnings like? Where are we now? And what are the unmet needs at the present time? How do you see TAVR in the future?
Well, again, in the beginning, TAVR began truly as an unmet need. In the 90s, we were confronted with an aging population of patients that were getting older, that had senile calcific aortic stenosis and multiple comorbidities, and were not good candidates for surgical treatment. And I had worked with Alain Crevier, and we became close friends. And two of my close friends who had worked with the early stent era with Johnson & Johnson at that time, before it became Cordis, Stan Rowe and Stan Rabinovich, the four of us founded a company to be able to truly, in a focused way, develop what we thought could be a transcatheter valve. At that time, it was a dream. Some people felt it was completely unrealistic. We were mocked by our surgical colleagues. Everyone thought that it had no chance of succeeding. In the beginning, we felt it likely would be restricted to the sickest patients who were not surgical candidates. But after the pioneering first cases that Alain Crevier did in Rouen, France, we transitioned and began doing clinical trials. And really that taught us that we could evolve the technology, improve the procedure, and that we could simulate what our surgical colleagues were doing in an operating room at the end of catheters very effectively. And we soon realized over the course of a decade that this could become not only a restricted procedure to the sickest patients, but could become the workhorse technology to be able to manage patients with aortic stenosis. And that set us in a direction that we still haven't fully realized, but with over 100,000 TAVRs a year in the US alone, it certainly has become the most commonly used therapy for aortic stenosis. The technology continues to evolve and get better. The procedures get simpler. Follow-up technology is improving. We're learning. We still have many new areas to conquer in TAVR to make it as good as it can possibly be in the future. So material science is getting better. Scaffolds are evolving in terms of, again, new materials. Clinical trials are becoming facilitated with our close relationship with the FDA. We've now taken TAVR to new dimensions in patients who are asymptomatic with severe AS. The next TCT, we're going to present the data on the PROGRESS trial, which is moderate aortic stenosis in patients who are at risk. So taking it into spaces that it never was in, even in the surgical environment. So we're continuing to push the edges, and we think the technology still has a ways to go. There are TAVR systems that'll be 10 or 12 French that can be allow treatment of patients within 30 minutes and in same-day procedures. The idea of, on a beating heart in an awake patient, to do a 30 to 60-minute procedure to allow patients to be ambulatory, to literally transplant a heart valve in a closed chest is pretty remarkable, I must say, and very powerful. And I think that vision is becoming a reality in the future.
Well, Marty, this has been a tremendous opportunity for you to share with us and our viewers your personal experiences, your professional career evolution, and what does the future hold for interventional field and interventional cardiology. I would like to thank you once again for this opportunity. And we hope that we will be able to maybe go a little bit more in detail and to talk about some other topics in cardiovascular medicine that were not covered in this podcast. Once again, thank you very much for participating in Living Legends and Luminaries in Cardiovascular Medicine. You certainly are one of the top ones in my mind that has achieved this through your illustrious career. Thank you once again.
Well, you're very kind. It's really wonderful to interact with your audience, and you do extraordinary things at the Texas Heart Institute. And I think that these experiences to share with others the career pathway of friends and colleagues is very meaningful. So thank you for the opportunity.
You're welcome. Thank you.